So I would like to now welcome Dr. Peter Voorhees, who is the Chief of the Plasma Cell Disorders Division and Vice Chair of the Department of Hematologic Oncology and Blood Disorders at Levine Cancer Institute. He is also a vice chair of the Alliance of Multiple Myeloma Committee. He is an experienced clinical investigator and has published extensively in the area of multiple myeloma. He will address the importance of clinical trials as they relate to multiple myeloma. Welcome, Dr. Voorhees.
Hello, everybody. So my name is Pete Voorhees, or Dr. Pete, as my patients like to call me, and I'm going to be talking about multiple myeloma and how multiple myeloma affects the Black community in the greater Charlotte area. I'm also going to be talking about the CHAMP project, which is one way that we're looking at Atrium Health Levine Cancer Institute to address the health disparities that we see in multiple myeloma in the community. So Dr. Thurtulian talked to you earlier today about multiple myeloma. So multiple myeloma is a cancer of plasma cells. So what the heck is a plasma cell? A plasma cell is a type of white blood cell that basically its job in life is to hang out in the bone marrow and crank out antibodies to fight infection. So if a normal plasma cell acquires the right set of DNA mutations and chromosome alterations, it can become cancerous and start to grow out of control. And when those plasma cells start to grow out of control, you then start to see the manifestations that are multiple myeloma. Now, as you learned earlier today, over 35,000 Americans will be diagnosed with multiple myeloma this year. When I first started doing this in 2004, we were diagnosing approximately 19,000 individuals each year with multiple myeloma. So the number of people who are being affected with this has clearly increased. And in fact, this is the most common blood cancer in the African American community. So what does multiple myeloma cause? And again, Dr. Thurtulian went through some of this, so I'll go through it quickly. Multiple myeloma causes bone destruction, which can lead to bone fractures, as Tony mentioned when he was giving his testimonial. It can cause bone pain as well. As the bones get broken down, the calcium from the bones can leach out into the bloodstream and cause the calcium levels in your bloodstream to get very high. And when the calcium levels in your bloodstream are very high, that causes you to be really tired. It causes nausea. It causes you to lose your appetite. And when it's really high, it can actually harm your kidneys. So the other thing is that multiple myeloma, as it grows in the bone marrow, it leads to ineffective bone marrow productivity. So it's not cranking out blood cells like it should. So the red blood cell levels drop. You become anemic. So you have less red cells to transport oxygen to your body, and that makes you feel tired. The antibodies that are made by the multiple myeloma can sprinkle in your kidneys and cause them to fail. And it's not unusual for someone with a new diagnosis of multiple myeloma to require dialysis for a period of time, hopefully not permanently. Multiple myeloma puts us at increased risk of infection. We think of the treatment suppressing the immune system and causing an increased likelihood of infection, but the disease itself is also very harmful for our immune system. So it's not unusual, for example, for somebody being diagnosed with multiple myeloma for the first time to have a new diagnosis of multiple myeloma. Blood work is done when they're hospitalized for their pneumonia, and then one thing leads to another, and then you've got a diagnosis. Now, as was mentioned earlier today, the diagnosis of multiple myeloma is commonly delayed in Black patients. It is more likely, so for our Black patients with multiple myeloma, they're more likely to have kidney failure at the time of initial diagnosis, and they're also more likely to be anemic at the time of initial diagnosis as well. So as was also mentioned earlier, multiple myeloma is the most common, blood cancer in the Black community, and in fact, it is twice as the incidence of multiple myeloma is twice as high than the white patient population in the United States and any other racial group or ethnic group that you see in the country. And not only that, but the mortality related to multiple myeloma is higher in the black community than it is in other racial groups. So this is an important blood cancer for everyone, but in particular the black community. So as Dr. Tertullian mentioned to us before, multiple myeloma is not what we consider a curable disease, but it is a disease that we are very good at treating. It's a disease that we're very good at getting into remission and driving it into remission for many years. And patients with this diagnosis can live many, many years. In fact, we've got many 20-plus year survivors nowadays, which was almost unheard of 10 years ago. So patients go through initial induction therapy. They may or may not get a stem cell transplant depending on how young and fit they are. Then they go on to maintenance therapy. So what we wanted to do at Levine Cancer Institute was better understand, what treatment looked like for the black community in the greater Charlotte area. So one of the things that we did is we looked to see what was the likelihood, that our black patients were undergoing an upfront stem cell transplant as part of their treatment. And as you can see here on this slide, 44% of our white patients in the green were getting upfront transplant in contrast to 35% of our black patients. Now that's all comers. These are patients in their 80s and 90s who wouldn't really be eligible for a transplant. So if we look at those patients who are 70 years of age or younger, those that are more likely to be candidates for stem cell transplant, you still see this disparity. So on the far right there, almost 2/3 of our white patients getting transplanted, whereas we only have about 48% of our patients are black patients that are getting transplanted. So we're diving into that to figure out why that's the case. And as it turns out, when they come to us, the myeloma specialist, to learn about transplant, they're just as likely to get transplanted as any other race. They're not getting to us. And we're looking at virtual health strategies and other things like that so more people can understand what the stem cell transplant process is, so we're applying it more equally across races. So what else did we look at? We looked at that initial induction therapy, that initial treatment to drive the multiple myeloma into remission. And as Dr. Tertullian told you earlier, there's a special triplet or 3-drug therapy that we consider extremely important. Nowadays, we're even doing 4-drug regimens, which are even more effective. But back when we looked at this analysis, it was the 3-drug regimen that was really important. And in the middle bars there, that's the most effective 3-drug regimen that we have. And again, the green bars are white patients. You could see that close to 81% of them are getting the optimal 3-drug therapy at initial diagnosis of their multiple myeloma, and only 2/3 of our black patients are getting that same therapy at initial diagnosis. So we dug into this a little further. Why the heck is this the case? Why are black patients getting suboptimal initial therapy? And initially we thought it might be because there's differences in kidney function at the time of initial diagnosis, because one of the drugs that we use, Revlimid, is harder to give for patients who have kidney failure. But when we looked at our patients, there was no difference in kidney function between races, so that wasn't the issue. Revlimid is a very expensive drug. It's an oral drug. It costs thousands of dollars, so we figured there must be an access issue. But when you look at the maintenance bars on the far right, and Revlimid is the maintenance drug that we use to treat myeloma, the rates of maintenance Revlimid therapy were virtually identical between black and white patients, so that wasn't the issue. So then we looked to see whether or not more patients were being hospitalized at the time of initial diagnosis. And the reason that I say that is because when patients are admitted to the hospital, the number of cancer drugs that are available to them at their disposal is more limited than when they walk into a clinic to receive their treatment. So we looked at this carefully, and about 10% of our white patients were being hospitalized at initial diagnosis with complications of their disease. In contrast, 25% of our black patients were being hospitalized with complications of the disease. That's 1 in 4 patients, and that's just absolutely unacceptable. And this is because the diagnosis is being delayed in this group of patients. So they start on suboptimal therapy, it still likely works, and they remain on that suboptimal therapy. We've changed this, now knowing this, so when patients get out of the hospital, we immediately switch them over to the optimal triplet, now quadruplet therapy to reduce that particular disparity. So why is it important that patients get the optimal 3-drug therapy at initial diagnosis? So we looked at this, and on the left here, this blue line, as it drops, that's somebody who's relapsing or someone that's passing away. And what you can see here is that the blue line, which is our patients that are treated with optimal 3-drug therapy, are doing better than those that are not getting the optimal therapy. And if you look at survival of any cause, for any reason, you can see that those that got the best 3-drug therapy are more likely to live than those that get the suboptimal therapy. So getting them on the right treatment at the beginning is absolutely critical. In spite of the disparities, in spite of the differences in upfront transplant, in spite of the differences in optimal induction therapy, as it turns out, at Atrium Health Levine Cancer Institute, our black patients are actually faring better than their white counterparts. So again, on the left, those lines dropping is people who are either relapsing or passing away. And as you can see, our black patients are less likely to relapse than our white patients. And the survival is actually more favorable for our black patients as well. And this gets to what Dr. Thurtulian was saying earlier today, is that there is a difference in disease biology. So our black patients, on average, have better risk disease, better risk biology than those patients who are white. But I would argue, that if we eliminate these disparities, we can do even better. So how can we address the disparity? How can we address the lack of timely diagnosis in the black community? So remember, Dr. Thurtulian told us earlier today that multiple myeloma doesn't just emerge out of thin air. So it starts off as a precursor condition called MGUS, which is a goofy acronym that stands for monoclonal gammopathy of undetermined significance. You guys are going to be quizzed at the end of the day. You don't get any raffle prizes unless you answer that question right. It's a precursor myeloma condition. Now, precursor myeloma, or MGUS, isn't invariably going to lead to multiple myeloma, but having precursor myeloma is a risk factor for developing full-fledged multiple myeloma. So the question is, could we potentially screen for the precursor condition so we can lead to more timely diagnosis? This is a really neat study, so I'm going to put on my hematology nerd hat, so I apologize. But this is a really neat study that they did at Mayo Clinic in Rochester, Minnesota. So there was a study that was conducted in California where nearly 78,000 individuals between the ages of 50 and 74 were basically getting blood samples done on a once yearly basis over many years. And as it turns out, 71 of these individuals over the course of time developed multiple myeloma. Now, this study was not done to look at multiple myeloma, but they went back to this treasure trove of blood samples that they had been getting on a yearly basis prior to that diagnosis of multiple myeloma. And what you can see here is if you go 6 years, 7 years, before that diagnosis of multiple myeloma, and you do the blood test we use to screen for multiple myeloma, you can actually see it in 90 to 100% of cases. So multiple myeloma invariably starts as this precursor MGUS condition. So why is multiple myeloma twice as common in the black community than it is in the white community? And the reason for that is because the precursor condition, MGUS, is twice as common in the black community as it is in the white community. So if you're twice as likely to have precursor myeloma, you're twice as likely to develop multiple myeloma. So the likelihood of precursor myeloma, or MGUS, turning into multiple myeloma is no different, for someone who is black or someone who's white. It's just that the precursor condition is more common in the black community. So this gets me to the CHAMP study. And this is something that we're initiating at Atrium Health Levine Cancer Institute at the beginning of 2025. So CHAMP stands for Charlotte African American MGUS Project. And what we're trying to do here is to address that disparity of timely diagnosis in the Black community in the greater Charlotte metropolitan area. And as I alluded to just a short while ago, all this requires is a single blood test. There's no imaging done. You don't have to go into a CAT scan machine. You don't have to have your chest smashed to look for abnormalities. It's just a simple blood test. And we've broken this down into two parts. There's a part 1 and there's a part 2. Part 1 is going to be what we're doing in 2025. And we're going to invite 1,665 individuals in the greater Charlotte area to be screened for the precursor myeloma condition MGUS. So you're eligible if you identify as Black, African American, if you're 30 years of age or older. That's it, okay? Now, the first part of this is really to assess the feasibility. Is this something that the community is going to embrace? Is this something that they're going to want to adopt? If not, what are the barriers to adoption of screening for this precursor myeloma condition? If we're successful in part 1, we will then pivot to part 2 in 2026, where we'll enroll an additional 8,335 participants to be screened with a simple one-time blood test for precursor myeloma. That's a total of 10,000 individuals over the course of this study. Anyone who tests positive for this precursor condition, this MGUS condition, will be invited to participate in a longitudinal study where we get people into the right folks for their longitudinal care so we can monitor them closely to see if they're exhibiting any signs or symptoms of multiple myeloma. And as I said before, we predict that detecting multiple myeloma at its precancerous stage is going to reduce delays in diagnosis, it's going to prevent myeloma-related complications, and it's going to enhance access to most optimal therapy. And by following many individuals with MGUS over time, we aim to identify unique biologic features of this precancerous condition in the Black community and what factors contribute to progression to full-fledged multiple myeloma. Is it the same factors in the white patients? We have a lot of information about this from Mayo Clinic, but it's all from white patients. We need a more diverse patient population to look at. So community engagement, this is a boots on the ground operation that will be running in 2025 and beyond. So community engagement is key. So you guys will be hearing more about this over the course of 2025 and beyond. We're going to need your help. So if you are interested in participating, please let me know. If you have community events that you think we should attend and to raise awareness of this initiative, please let us know. We want to get out there, boots on the ground, work with you to make this successful. And I have my contact information here, both my phone number and my email address. So with that, I will wrap up and thank you so much for your attention.